Hello, this is Dr. Brett Bernstein. Today's webinar will be on PQRS, which is the Physician Quality Reporting System, and I'm going to give you a primer on present and future requirements. Now, like all government programs, this one is rather technical, and what I'd like to do over the next hour or so is give you some of the background, then discuss some of the technical aspects of how to successfully report under this program, and then end with some practical advice. As far as background, the PQRS program was devised in 2006. It was signed into law at that time under the Tax Relief and Health Care Act. It subsequently underwent further changes in 2009. And most recently, in 2011, was changed from the Quality Reporting Initiative to the Physician Quality Reporting System. This program is a voluntary individual reporting program that provides an incentive payment to eligible professionals who report data on quality measures under Part B of the Medicare plan. Eligible professionals do not have to sign up or pre-register to actually participate in this program. The bad news is that future claim payment adjustment amounts for non-participation in this program will be occurring beginning in 2015. So you will be penalized for non-participation. There is in 2013 and 2014 incentives of 0.5% still available if you successfully report. And beginning in 2015, there will be a 1.5% negative adjustment based on non-reporting this year. Now, how does the program work? Eligible professionals will review the current year's measures and select from those listed that are applicable to their own practices, which we'll discuss later. They then systematically must determine if the surface being measured was provided. And finally, eligible professionals must report the performance of the applicable measures. This is a comprehensive list of those who are eligible. Today we're obviously focusing just on physicians. However, physicians' assistants and nurse practitioners, as well as other extenders, may participate in this program. The number of measures this year is up to 259. In 2014, there will be 288 measures. Each measure is assigned a unique number and consists of two major components, a denominator and a numerator. The denominator describes the eligible cases for a measure, meaning the eligible population associated with the numerator. Basically, these are determined by physician quality reporting eligible CPT Category 1 codes, as well as eligible HCPCS codes and an ICD-9 code if applicable, as well as patient demographics. This is a screenshot of the diabetes denominator, as well as the associated ICD-9 codes, which are quite extensive, in addition to the patient encountered during reporting period CPT or HCPCS codes. Now, the numerator describes the clinical action required by the measure for reporting and for performance. And these are indicated by what are known as quality data codes, which are non-payable codes, which are comprised of a CPT Category 2 code and or a so-called G code that describes the clinical action required by a measure's numerator. These CPT-2 codes are not modified during the reporting period and are valid for the program year that are specified within the specific measure. So each component is defined by specific codes described in each measure specification, along with reporting instructions and use of modifiers. What you're seeing here is a snapshot of 2013, the quality reporting system data codes. And although somewhat intimidating looking as a chart, if you follow it from left to right, here you have the PQRS number, followed by the National Quality Forum measure number, and the codes that are associated with meeting performance or in some cases if there's an exclusion, which I'll discuss in a moment. So as an example, again, here we are looking at the measure of patients with the most recent hemoglobin A1C level greater than 9%. Instructions for the numerator are quality data coding options. So the CPT2 code here is 3046F. Or if this was not performed and a reason not specified, then you have to append with an 8P, which I will go through in a moment. So these exclusion modifiers indicate that an action specified in the measure was not provided due to one of several reasons. It could be medical, patient, or system reasons that are documented in the medical record. And not all measures do allow, however, for performance exclusions. These exclusion modifiers need to be added to the applicable PQRS measure code. It's important to read each measure fully and only append the performance modifier if the measure denotes the use. So, in the example, 1P is the performance measure exclusion modifier that's used if there are specific medical reasons, such as the test was not indicated, such as the test being already received or performed, or if the test was contraindicated, such as due to allergy, adverse drug interactions, or other reasons. 2P is a performance measure exclusion modifier that's used if there are patient-specific reasons, such as the patient declining the examination, economic, social, or religious reasons, as well as others. 3P is referring to that resources that are normally available to perform services are not present in your particular venue. Insurance coverage or payer-related limitations. And finally, other reasons attributable to the healthcare delivery system. The final measure is 8, which is the exclusion modifier, which may be applicable for a given measure. Certain measures have no applicable exclusion modifiers and refer to the measure specifications to determine the appropriate exclusion modifiers. So again, 8P is if the action is not performed, the reason not otherwise specified. This will allow you to get credit for satisfactorily reporting, but the provider will not receive credit for performance. Now, what about reporting frequency? Each measure has a designated reporting frequency requirement for each eligible patient seen during the reporting period. This frequency will be specified within the individual measure. So how do you start? First, obviously, as medical doctors, you are all eligible to participate, assuming that you accept Medicare Part B. As providers, you should review the measures and determine which apply to the manner in which your practices and the types of patients treated in the practice fit in, and select the appropriate number of measures to report based on the program guidelines. And finally, review the various reporting options, which is what we're going to do here. As far as individual measures, each year CMS publishes a listing of the individual measures specific for claims and registry reporting. Each measure has a numerator and a denominator, which permits the calculation of the percentage of a defined population that receives a particular process of care or achieves an outcome. Again, these measures also consist of specific instructions regarding coding. The next slide, which we're going to look at, is a screenshot of the 2013 measures list, which can be found under the download section in the 2012 or 13 Physician Quality Reporting System measure list. I've listed the URL so you can access that. So again, if you look at this screenshot, this is just from one of the first pages, and what you see on the far left is the National Quality Forum assignment, the PQRS number, the domain under which the particular measure occurs. The National Quality Strategy consists of 6 domains. Here you see these particular ones are under clinical process and effectiveness, a brief description of the measure, the developer, and the manner in which you may report this measure as part of the PQRS system. Now, the individual measure, which we'll discuss on the next slide, which is hemoglobin A1C poor control of diabetes, is provided as an educational example. Here you see that this measure can be reported under a claims methodology or registry. I will be reviewing both of those. The description of the measure is the percentage of patients aged 18 through 75 with diabetes who had their most recent hemoglobin A1C greater than 9%. Here you see the description of the reporting period, which means once every 12 months. In terms of reporting, the measured title is listed in the example above, along with the applicable reporting options available. And again, this can be reported by claims-based or qualified registry. The eligible population for this measure includes patients with a denominator CPT code that matches between the ages of 18 and 75, who have had one of the eligible ICD-9 codes for diabetes in their billing data submitted on the claim. The ultimate statistic reported by this measure is the percentage of patients with diabetes age 18 to 75 where the A1C control is poor. Again, the measure details the frequency of billing the measure. This measure needs to be reported a minimum of once per calendar year. Now, getting back now to finally the meat of how we do this, the reporting options under the PQRS system are really four main ones. There's claims-based reporting, which can be done with individual measures or what are called measures groups. There is registry-based reporting. CMS publishes a list of qualified registries. There is reporting through use of an electronic health record if you are utilizing one. And there is also a group practice reporting option. Finally, there is a method of simply reporting using an administrative claims methodology where an eligible professional group practice can have CMS analyze claims data to determine which measures an eligible professional or group practice reports. For the 2015 adjustment only, this is used, and under this reporting mechanism, physicians or group practices need to complete an election for this method by October 15th of this year. But you must note that if you do use this methodology, its only purpose is to avert the adjustment in 2015. You will not be getting any credit for the work that you do. Now on to the flow chart. We're going to take a look now at claims-based reporting options. Essentially, we'll follow this down. You can see that you have to utilize either 3 or less than 3 measures. The reporting for these criteria are January 1 of 2013 to December 31st, 2013. You have to report at least 3 physician quality reporting system measures. Report each measure for a minimum of 50% of the eligible Part B Medicare patients seen during this period to which the measure applies. If a measure has a 0% rate, it will not be counted towards your performance. Providers who report fewer than 3 measures during the reporting period could be subject to measure applicability validation, meaning an audit. Now, eligible providers selecting the claim methodology have to select the CPT Category 2 code, which we previously discussed, which supplies the numerator. Multiple CPT Category 2 codes can be reported on the same claim as long as the corresponding denominator codes are also on the claim. In addition, the individual NPI of the participating physician needs to be properly on the claim, and the correct numerator has to be reported on at least 50% of eligible claims for each selected measure or measures group. It is advisable to aim higher in case there are challenges with claims. In addition, you have to indicate the ICD-9 code as well as a CPT Category 1 encounter code on the claim, and these need to match the diagnosis and encounter codes listed in the denominator criteria of the measure. You also have to remember that the submitted charge field cannot be blank. This item as a line item to be charged as $0. In some electronic systems, this is not allowed, in which case you should put a nominal amount such as 1 cent. Remember that claims with a zero charge may be rejected. In addition, as a provider, you must be part of PQRS, which is the electronic filing system for Medicare. Make sure you file claims timely. As far as follow-up, if you're using claims, as physicians, you should make sure that your billers follow the remittance advice for a denial code for the measure-specific code and confirm that it has passed through the correct carrier. An N365 denial indicates the code is not payable and is used only for reporting and informational purposes. This is what you should expect. Now, quality reporting also includes the action not performed, as well as documentation of contraindications or exclusions. But for each physician, you must report at least once the desired quality action for each measure submitted. So with A1C, the desired outcome is good control of this measure, so that this needs to be reported at least once per measure. The measure itself, as I discussed previously, is calculating poor control, so a high score on this particular measure actually means poor quality, not good quality. I won't spend much time on this, but this is an example of a typical HCFA form, and what you can see here is that this patient was seen in the office with a code of type 2 diabetes, as well as coronary disease. Below that, what you see here listed are the CPT codes that we were discussing. So that 3046F is diabetes measure 1, 4011F is coronary artery measure 6, and 2P means that oral antiplatelet therapy was not given to the patient for a specific reason. Again, this is just going through the fact that a zero charge should be entered on the charge field. If you can't enter a zero within your system, then enter a small monetary amount. Make sure that your NPI and or the rendering provider's NPI number are submitted on the claim. Use of these fields is dependent on the type of provider, solo or group billing. Common claims-based errors that do occur are the patient's age and or gender mismatch to the measure reported, an incorrect diagnosis and or HCPCS code mismatch to the measure reported, a measure that's reported without an eligible encounter, and no quality data code submitted on the eligible claim. So just as an example, for measure number 6, which is presence of coronary artery disease and the use of antiplatelet therapy, Mr. Jones presents to the office for a visit with Dr. Thomas and is diagnosed with CAD. There are 3 scenarios here. Dr. Thomas prescribes aspirin and Plavix, in which case a 4086F would be what is reported as a QDC code. Scenario 2, where the patient did not receive aspirin or Plavix for medical, patient, or system reasons, this 4086F has to be appended with the 1P, 2P, or 3P suffix. And then finally the 8P, which would be used if the patient did not receive aspirin or Plavix, but no reason was given. In terms of technically what happens to your documentation using a claim, the visit is obviously documented in the medical record, an encounter is made out, coding and billing occur, and right here is the critical step where this is sent to the carrier. It goes to the National Claims History File for analysis. Reports can then be obtained through a government website, which I'll discuss shortly. And then, assuming that this is validated by the carrier, you will receive your incentive payment. Now, another option for reporting is using a CMS-approved registry, and you can report using a registry methodology, either individual PQRS measures or measure groups. So as far as registry options, you choose from a list of CMS-approved registries. Once you have selected one, you'll be required to enter into and maintain a legal agreement. these arrangements provide so that the registry's receipt of patient-specific data can then be released on behalf of CMS. You must report the TIN and individual NPI to which Medicare Part B charges are billed. CMS analyzes the PQRS data strictly by the federal tax ID shown on Part B claims that you are submitting. So on the CMS 1500 paper form, that's field 25, where you enter a 9-digit number, and then check whether it is a social or an employee ID number. You should use your individual rendering NPI, not the group NPI, and the individual or rendering provider ID field is 24J on a paper claim, and this is not applicable to the group provider reporting option. This is a screenshot from the CMS website of some of the available registries, and they provide you with what the specific registries are able to do, including whether you can do individual measure reportings or measure groups are supported, the URL or email of the specific registry is also given. This is a screenshot of one of the better registries which I found quite simple. This is from one of the available pages. You can see in the left panel they actually have a series of video tutorials on how to use a registry. In addition, they have measure groups on the right, which when clicked upon will give you the actual measures included. It's a fairly self-explanatory methodology that's used. After paying your fee and entering the appropriate data and signing an electronic agreement, you enter the appropriate parameters into this table which appears at the bottom that's specific for the measure that you choose. Now, as far as groups can report via claims or registry. The advantage of measure groups are that it requires only 20 unique Medicare Part B patients if you're reporting via claims, and it requires only 20 patients. 11 of 20 must be Medicare Part B if you're using a registry. The disadvantage of measures groups are there are a limited number of them, and you can only report them via claims or a registry. Here I'm just showing an example at the top of what constitutes the PQRS diabetes measure group, and you can see it consists of 6 measures, which include hemoglobin A1C, an eye exam, attention for nephropathy, foot exam. There are specific measures groups which can be utilized with registry or claims, and then there are several which can only be used with a registry. Further information can be obtained at the AMA website. This is a screenshot. If you enter PQRS, this will take you to a very helpful data repository of all of the actual group measures, which you can then download. From a practical standpoint, for those of you who are predominantly practicing primary care, probably the most efficient and easiest way of achieving PQRS compliance is to use a registry and to use the measure group of preventive health care, as most of the items under this category are performed by primary care doctors on a regular basis. So as you can see, the measures included for preventive health care include screening for osteoporosis, flu vaccines, pneumonia vaccines, breast cancer screening, colorectal screening, and the last 3 being truly the easiest and most commonly used, which are body mass index, unhealthy alcohol use screening, and tobacco use screening and cessation intervention. So, to summarize, measure groups reporting can be used under a claims methodology or a registry methodology. The registry methodology probably represents the easiest method of being compliant with PQRS. I'm not going to spend much time in this, but there is also a group practice reporting option. Group practices, the advantage or benefits of participating with PQRS as a group practice is that the billing and reporting staff can report just one set of quality measure data on behalf of all the eligible physicians within a group, which reduces the need to keep track of reporting efforts separately. The methodology for what defines a group has changed. A group practice is now defined as a single tax ID with 2 or more eligible professionals as identified by their MPIs who have reassigned their billing rights to the TIN. The definition of group practice to include groups of 2 to 24 eligible professionals, and beginning in 2013, all group practices will be able to participate in the PQRS group practice reporting option. Now, how do you participate as a group? First, what you need to do is self-nominate. Group practices will submit a self-nomination statement via CMS website, which I'll show some screenshots of, and this needs to occur by October 15th of this year. You then need to choose a reporting mechanism and criteria, which is a choice of either using a group web interface that is on this QualityNet website, which I'm going to show in a moment. You can also report via registry, and finally, administrative claims. Beginning in 2014, the electronic health record-based reporting mechanism will also be available for use under the group practice reporting option. This is a screenshot of QualityNet, which is the only approved government website, which allows you to have access to your own PQRS reports, but is also used to obtain an identification number and is also used for the reporting of PQRS data using the group practice reporting option. This is a screenshot of the actual registration screen. This is summarizing this wordy slide, the method by which groups can report under PQRS. So if you are a group of anywhere between 2 and 24 physicians, your reporting method needs to be via registry, and what you will be doing is submitting greater than or equal to 3 PQRS measures on 80% of your applicable Part B patients. If you're part of a larger group of 25 to 99 physicians, you will use the web interface, which I just showed you a screenshot of, and data fields need to be populated for the first 218 patients who are under Part B for your group practice. Larger practices is 411 consecutively ranked and assigned patients. Now, what about the option of using EHRs? Well, there are 2 methods for submitting PQRS data using electronic health records. This can be a direct EHR, meaning if the electronic health record that your practice is using has the ability to do so, it can directly submit PQRS data. The other possibility is that your EHR may not be certified to do this, and you may have to go to a secondary vendor which can extract data from your EHR and then report to PQRS. The 2 options here are to use the EHR to report individual measures. There is also a method, however, which is currently available that allows you to get credit for PQRS at the same time as getting credit for meaningful use of your electronic medical record. In order to achieve that, using your electronic record, you do have to report 3 core measures. The core measures include body mass index, blood pressure measurement, and tobacco use screening and cessation. If you're unable to fit your patients into one of these criteria, you may use one or more of the alternate core measures seen below. In addition, 3 of the following measures here need to be reported in addition to the core measures. And if you're able to achieve that with your Part B beneficiaries using your EHR, then you will receive not only the incentive for PQRS, but also for meaningful use of an electronic medical record. Finally, there is a methodology for 6-month reporting, which starts from July 1st of this year to December 31st, which is through utilizing a registry and measures groups. And again, as I discussed, you would only have to file for 20 applicable patients, 11 of whom must be Medicare B patients. Now, in summary, how do you avoid the payment adjustment for 2015? There are really 3 ways. One is to meet the criteria for reporting of the 2013 PQRS incentive. If you report just one valid measure or measures group using claims registry or electronic health records, you will avert the adjustment, but again, will not get the incentive. And finally, the easiest way is to simply file through the CMS website to be analyzed under the administrative claims-based reporting mechanism. For 2016, there's currently only one way of avoiding the payment adjustment, and that is to meet the criteria for satisfactory reporting for 2014 incentive, although CMS says it may establish additional ways to meet the criteria for satisfactory reporting in the future rulemaking. This also applies to those who are filing under the group practice reporting option. So in the end, you need to participate because performance will be the basis for payment in the near future, which is within the next couple of years. And finally, there's a Physician Compare website which already has begun. You can simply go to CMS and access your name, and on this site will be, in the future, your measure of participation and performance in programs such as PQRS. For those of you who are interested in reading further about this, I've provided the appropriate references. I thank you for your time.